what? That's not what we want. We want this one. Okay. Sam. He's a 69-year-old man with pertinent medical history, lung disease. Oh, sorry. I'm reading the wrong thing. I was reading you the answer. He owns his own business. The stress of overseeing his employees, meeting deadlines, and carrying out negotiations has led to poor sleep habits. He sleeps 3 to 4 hours a night, and he keeps himself going by drinking 2 quarts of coffee a day. That is a lot of coffee. And smoking 3 to 4 packs of cigarettes. So if he's not ingesting coffee, he has a cigarette in his mouth. He weighs 280 pounds, and he does not drink. His wife complains that his snoring has become difficult to live with. Looks like he likes donuts, too. So, as a clinic nurse, what information would you want to obtain from Sam? What do you want to... So we know that he's stressed out, he's overweight, he can't sleep, he smokes a lot. What else do we need to know? He's snoring, coming in because his wife's mad. Has he been evaluated for sleep apnea? Well, what else do we need to know? We're coming in here, we're doing our first assessment. How long has he been smoking is good. How about assessing his lungs? How about assessing those other things that we get a lot of information from? Vital signs? Vital signs and pulse oximetry would be a good thing to do. Medical history, pertinent medical history. What would that be like? Well, tell me what it is. This is a guy that... Does he have CHF? Does he have any respiratory issues?
Surgery, hospitalized.
Does he have asthma? Has he ever had asthma? He's snoring.
4 hours a night, is that like his normal, or is that like
I used to sleep great. What else could be causing, we're thinking about snoring, what else could it be?
his overweight and his neck?
And this? Sinuses? Does he have chronic sinusitis? Anybody who has a sinus infection, what are you doing when you're sleeping? Right? Because you're all plugged. Everyone snores to some degree, some of us more than others. What are the environmental factors? Do you have a cat allergy and your wife has 7 cats? You know, what's going on? Like, do you have any environmental factors? Are you allergic to dust mites, animal dander, nasal problems? We sort of talked about that already, but do you have a deviated septum where you punched in the nose ever? Get a basketball to the nose? Ever had that happen to you? Hurts. And allergies and any current meds, over-the-counter, and herbals. We have to make sure we ask our patients always about over-the-counter meds and herbals because they're still medications, right? For example, an herbal preparation of foxglove. What is that? Digoxin. That's a pretty potent drug, right? And we know digoxin doesn't get along with anybody, right? Digoxin, you can't give it at the same time. It's always on its own because it's not friends with any other medications. So an herbal prep could also interact with other things that anyone is on. Over-the-counter meds. If this guy was hypertensive, over-the-counter cold remedies will do what to him? What do cold remedies do? The blood pressure is going to go up because what do cold remedies do? They vasoconstrict. Whatever you stick in your nose, it's going to constrict. Whatever you take in is going to constrict to open up your airway passages, etc. So it causes vasoconstriction. So after interviewing him, he does have hypertension, you see he has a blood pressure of 164/90, heart rate's 92, respiration's 18, his O2 is 90% on room air. He's under considerable stress, 50 pounds in the last year, history of tobacco, caffeine abuse, difficulty staying awake, wakes up with headaches most mornings, has mid-morning somnolence, is depressed, irritable most of the time, reports difficulty concentrating and learning new things, and he's been in 3 auto accidents over the past year. He hasn't had a good year. Packed on the weight and crashed the car 3 times. So, your examination is normal, except for multiple bruises over his right rib cage, and you inquire about the bruises, and Sam reports that his wife jabs him with her elbow several times every night, and in her own defense, she says, well, he stops breathing, and I get worried, so I jab him so he'll start breathing again. So, you suspect sleep apnea. Now, these are the patients these are the people, they probably don't know they have sleep apnea. It's their partner that identifies it. And this is how they go. They go. Right? Like that. That's a sleep apnea person because they've quit breathing. You're going to love this song. Christine, when you listen to this, you're going to love it. She just told me that she listens to me all the time. Your best friend. So I snorted for you. That was all for you. Okay, so there's 2 kinds of sleep apnea. Central sleep apnea is pretty rare. There's actually a deficit where there's the signal down to the respiratory muscles isn't there. So that's central sleep apnea. It's pretty rare. But what we have to think about is obstructive sleep apnea. And obstructive sleep apnea is most common. And I actually have personal experience with this because I've just been diagnosed with mild sleep apnea. Lucky me. So I can talk personally about this stuff. So the reason you want to get it fixed, and so I've been ignoring my sleep apnea for a long time, and then every time I give this lecture, I'm like, yes, I could eventually get MI, hypertension, arrhythmias. Over a prolonged period of time, it can lead to pulmonary hypertension, right-sided heart failure, polycythemia, and a CVA. So I choose to get it treated. No more ignoring it. But, ignoring is coping mechanism is pretty good. So the mechanism is unknown. However, uncontrolled diabetes is also associated with sleep apnea. And they have found if diabetes gets into control, their sleep apnea is in control. And I can't really figure out the physiology behind that. And I guess that's why it's unknown, because it doesn't really make much sense. So the 5 signs or symptoms of obstructive sleep apnea. Someone tell me.
They're irritable during the day.
Mm-hmm.
They're tired.
Tired, irritable.
Even after a long night's sleep.
Feel like they don't have enough sleep. What does he have? What did he have? Mid-morning somnolence. Well, he had this. His wife said that he did this for sure. He has cessation of respiration. He had daytime fatigue. Not feeling rested. He did complain of that. Memory loss. He didn't really complain about that. Poor judgment. Lethargy. High blood pressure. Confusion. Headache. Weight gain. He's had weight gain, headache, high blood pressure. So the risk factors are obesity, a large uvula, a short neck. So these are individuals, I would say they look like a turtle man, with the recessed jaw. You know what I'm talking about? Look, see, if you look at this guy from the side, he doesn't have much of a chin. Sort of his chin and neck goes in together, so it's recessed. He's got a short little neck. And so there's a higher risk of all that soft tissue falling back upon itself, right? If they have enlarged tonsils, adenoids, and any oropharyngeal edema, it increases with age, and it's more likely in men than in women. So tests used to diagnose? Anyone want to go out there and tell me what they are? A sleep study. They do an overnight screening oximetry test. So what happens is you go home with this little, it's almost like this picture here. You have a little belt around your chest that's measuring your respirations. You have a pulse ox on and a nasal cannula, not to O2, just to room air, and a magic box that records all this stuff overnight. I didn't get the funky head thing, though. I just had that other stuff. So that's an overnight screening test. If the desaturation is present, they probably will go to a polysonogram, which is the gold standard, and that's where they have to go to a sleep lab, and they have to, have a long study where they get the probes on the head and everywhere else. Although it's difficult for individuals to do that because sleeping in a strange place, a lot of people don't get through all 4 stages of sleep when they have this done. Limited channel monitoring is been developed. They'll use that also when, and I really think it's so that the insurance companies don't have to pay for the other one. But it does help with diagnosis. And then a physical exam and obviously a history. So the primary care provider examines Sam and documents a long, soft palate, recessed mandible, and medium-sized tonsils. He's a turtle man, right? Looks like kind of like a turtle. His overnight oximetry study shows 143 episodes of desaturations ranging from 68% to 76%. And he was diagnosed with significant sleep apnea. And a full sleep study was ordered, and you're supposed to talk to him. And what are you going to talk to him about if you come up with these results? What would you say? You're now passed off for the education. Lose weight. Quit smoking. Quit smoking. What else? Decrease your coffee intake. Avoid sleeping on your back, because you snore when you're on your back. One strategy, give me a strategy of how to avoid sleeping on your back. Another one? But you roll onto your back. Oh yeah, if everybody could afford one of those. Especially if you have a partner, like what sense does it make? You'd have to get independent moving ones, right? Yeah, but they're $10,000 more than the one that moves like this. We'd have major fights over that, I'll tell you. Here is the simple solution that's been around for a long time about avoiding back sleeping. You sew a pocket into the back of your shirt or whatever you wear to bed, and you put a tennis ball in it. It is probably in the textbook even. You don't like to roll. If that's in between your shoulder blades, when you roll on it, you're not staying on your back. You could put a cue ball in there and it would really wake you up. So you avoid back sleeping, avoid narcotics, benzodiazepine, muscle relaxants, alcohol. I mean, this guy doesn't sleep or doesn't drink, but he shouldn't start now, and he shouldn't take any sleep aids, because this is a cycle that people who have apnea can get into. I'm not getting enough sleep. I'm tired. I'm going to take something. And now I'm going to have 143 episodes. I'm going to go to 240 episodes because I can't wake up because I'm just lying in there with my mouth open, snorting. So you've gone to work over the emergency department. Have you noticed how Sam has changed from a cartoon character to different ethnicities throughout this? Yeah. He's asleep at the wheel, and he lost weight. He did. So you're working in the emergency department, and the medics bring Sam, who states he fell asleep when driving to work and wrecked his car. Oh, Sam, what are you doing here? And his vital signs are within normal limits. He has a pulse ox of 92 on room air, and he complains of rib pain from the airbag release, and his chest x-ray indicates 65% pneumothorax on the right. You put him on 2 liters of nasal cannula, and his sats go to 96. What are you going to be prepared to do? Release the pressure. You personally aren't going to do that. So what are you going to do? Prepare for a chest tube insertion. Oh, here's our cue.
Today you're assigned to care for a 24-year-old patient who was recently admitted with a chest wall injury caused by a car accident.
Are you having trouble breathing, sir? Okay. Is anything making it worse?
During your initial assessment, he reports shortness of breath and a sharp pain on the left side of his chest on inspiration. A stat chest x-ray confirms a left-sided pneumothorax. Now you must act quickly and help insert a chest tube to correct the problem and prevent further respiratory compromise.
Mr. Smith, I'm just going to give you a little bit of oxygen.
Your role in chest tube insertion and management is critical because your patient's life depends on your skills. To help you perform the role expertly, this program will show you how chest tubes work inside the body to relieve a pneumothorax or similar condition. You'll also learn how to assist with chest tube insertion and removal, set up and maintain a chest drainage system, monitor for complications, and provide other follow-up care. Chest tubes and closed chest drainage systems are ordered to remove fluid or air from the pleural and mediastinal spaces.
Right here to help you breathe.
These devices are used to manage open or closed pneumothorax, or air in the pleural space, pleural effusion, or fluid in the pleural space, empyema, or pus in the pleural space, hemothorax, or blood and air in the pleural space, and recovery from thoracic surgery. To understand how chest tubes and drainage systems work, consider the normal anatomy and physiology of the lungs and related thoracic structures. These elastic structures normally expand and contract to allow for respiration. During inspiration, the intercostal muscles contract to expand the chest wall, and the diaphragm contracts and moves down to create negative pressure in the lungs that allows them to fill with air. During expiration, the diaphragm and intercostal muscles relax, which allows the elastic recoil of the lungs to force air out. 2 pleural membranes help make lung movement possible: the parietal pleura, which lines the thoracic cavity, and the visceral pleura, which covers the lungs. Pleural fluid lubricates the surfaces of these membranes so they can move against each other smoothly. Negative pressure in the pleural space forms a vacuum which keeps the pleural surfaces together and prevents lung collapse. However, if a pleural membrane is disrupted, the delicate balance can be disturbed. For example, if a fractured rib punctures the parietal pleura, a pneumothorax can occur. In a pneumothorax, air enters the space between the parietal and visceral pleurae, destroys the negative pressure that holds the pleurae together, and prevents normal ventilation. If air continues to enter the pleural space during inspiration and can't escape through the break in the pleura during expiration, a pneumothorax can become a tension pneumothorax. In this life-threatening emergency, pressure in the pleural space increases, further compressing the affected lung. If the pressure builds, it can compress blood vessels and shift the mediastinal contents, including the heart and bronchi. Without treatment, tension pneumothorax can lead to cardiac arrest. Chest tubes and drainage systems help relieve a pneumothorax by restoring the negative pressure in the pleural space, which allows the lung to re-expand.
So, Mr. Smith, we are going to put this chest tube in.
When your patient needs a chest tube, prepare him by explaining the procedure and providing reassurance, making sure that the physician has obtained informed consent, and administering an analgesic or a sedative as prescribed. Also, prepare the equipment, including the closed chest drainage system. To understand how this type of system works, consider its components. A disposable drainage system usually has 3 chambers, each with a different function. The drainage collection chamber collects and measures blood or other fluid that drains from the pleural or mediastinal space. It usually has at least 2 compartments to capture large amounts of drainage. The water seal chamber has a one-way valve to create negative pressure that lets air and fluid escape from the pleural space and prevents air from being pulled into the pleural space. The water level in this chamber reflects conditions in that area. For example, if pressure in the pleural space unexpectedly rises, the fluid level in the water seal chamber will fall. This chamber can also detect air leaks in the system or pleural space. In systems without a water seal chamber, an air leak monitor serves that purpose. The suction control chamber is found on systems that use wet suction. In a wet suction system, this chamber uses water to create the negative pressure needed to remove fluid or air. In contrast, a dry suction system uses a built-in device to regulate the suction amount. Generally, dry suction systems are preferred when high negative pressures are needed. Before chest tube insertion, prepare the drainage system. Fill the water seal chamber to the 2 centimeter mark. For wet suction, also fill the suction control chamber to the prescribed level, such as negative 20 centimeters of water. With the drainage system assembled, prepare a sterile field for chest tube insertion. For an uncomplicated pneumothorax, expect the physician to use a 14 French or smaller chest tube. To drain thick fluid or remove fluid or air rapidly, expect the physician to use a larger diameter catheter.
Okay, and lean over this table.
Help the patient into an appropriate position. If he can tolerate sitting upright, have him lean over a bedside table to accommodate a tube in the 4th or 5th intercostal space, usually lateral to the nipple line. Otherwise, help him into the lateral supine position with the affected side up. In a pneumothorax, air tends to rise high in the thoracic cavity, so the physician will direct the tube anteriorly toward the apex of the lung. In a hemothorax or empyema, gravity causes blood or other fluid to collect in lower areas, so the tube will point posteriorly and toward the base of the lungs.
Mr. Smith, let me see your ID badge.
Before the procedure begins, be sure to follow JCAHO's Universal Protocol for preventing wrong site, wrong procedure, and wrong person surgery. To do this, mark the surgical site if the physician leaves the patient before starting the procedure, and call a timeout while the patient's awake in order to verify his name, identify the procedure, and confirm the surgical site. Next, assist with the procedure. Expect the physician to apply antiseptic to the insertion site. Then expect her to inject a local anesthetic, such as lidocaine, to numb the area. While the physician inserts the chest tube, reassure the patient and assess his pain level. Administer another dose of analgesic if indicated and prescribed. After the chest tube is in place, help the physician connect it to the drainage tube on the closed chest drainage system, keeping the connector sterile. As ordered, set up wet suction, dry suction, or gravity drainage. The type used depends on how much air must be removed and how quickly the pneumothorax must be resolved.
Try to relax and let the chest tube do its work.
If suction is ordered, attach the tubing from the suction control chamber to an external suction source, such as wall suction. For wet suction, increase the suction on the external source to produce gentle, continuous bubbling in the suction control chamber. For dry suction, set the external source to 80 millimeters of mercury and set the suction control regulator on the chest drain to the prescribed amount. For gravity drainage, leave the suction tubing open to the room air. This lets air escape from the chest drainage system. After the physician sutures the chest tube in place, apply a dressing to the insertion site. If ordered, use petrolatum gauze to create an airtight seal around the tube. Then apply a dressing, such as fenestrated or split gauze and 4x4 occlusive gauze, and tape the entire surface of the dressing. Secure all tube connections with tape or nylon bands to help prevent an air leak. As ordered, arrange for a chest X-ray to confirm tube placement in the patient's pleural space. After chest tube insertion, perform follow-up care. Initially, check your patient's vital signs every hour. Watch for hypotension, tachycardia, and tachypnea, which can signal a tension pneumothorax. In this complication, positive pressure in the pleural space compresses blood vessels and decreases cardiac output, the amount of blood the heart ejects in 1 minute. Low cardiac output causes hypotension. To compensate and raise the blood pressure to normal, the heart beats faster, which results in tachycardia. Also, auscultate your patient's lungs at least once every hour initially. Expect clear breath sounds to extend to the periphery of the lungs, a sign of reinflation. If the lung sounds remain diminished on the affected side, the chest tube may not be resolving the pneumothorax and may need adjustment, replacement, or increased suction.
Okay, good.
Remember to check the patient's oxygen saturation every 2 to 4 hours or as ordered. Report a level that's below 95%, a sign of hypoxemia caused by impaired ventilation. Remind the patient to cough and deep breathe at least every 2 hours. Doing so can help reinflate the lung and ease his breathing.
0 is no pain at all.
Regularly ask him about incision pain and pain with deep breathing, and administer analgesics as prescribed.
Just double check. Good.
Pain is common after chest tube insertion. That's because the procedure disrupts the parietal pleura, which contains pain receptors from the intercostal nerves. When triggered, these receptors send pain signals up the spinal cord to the brain. Check the chest tube dressings frequently to detect blood or other drainage. Change the dressings according to hospital policy. Also, palpate around the insertion site to detect subcutaneous emphysema. This complication occurs when air leaks into subcutaneous tissue and produces crepitation or a crackling sound on palpation.
How are things going here?
Well, actually, doctor, I think there's a little crepitus.
If you detect subcutaneous emphysema, immediately notify the physician, who may reposition the chest tube. To facilitate chest drainage, reposition your patient at least every 2 hours and maintain a high Fowler's or semi-Fowler's position if tolerated. Check the character and volume of the chest drainage once every hour or more often. Near the drainage chamber, mark the date, time, and fluid level according to hospital policy. Notify the physician if chest drainage exceeds 100 milliliters per hour. Excessive drainage can signal hemorrhage, which may require surgery. When the drainage collection chambers are nearly full, replace the system. To do this, prepare the new system and clamp the chest tube. Then quickly disconnect the old system and reconnect the new one. After unclamping the chest tube, make sure the drainage system is working properly. Regularly check the water seal chamber for tidling. The water levels normal rise and fall with respiration. During inhalation, the pressure in the pleural space becomes more negative, raising the water level in the chamber. During exhalation, the pressure level returns to baseline, and so does the water level in the chamber. The absence of tidling commonly indicates an obstruction, which can occur when the tubing is kinked, compressed, or clogged, or has a dependent loop. Absence of tidling can also occur when the lung is reinflated because the negative pressure in the pleural space is restored. Also look for bubbling in the water seal chamber. Normally, you should expect bubbling immediately after the drainage system is attached to suction, when a small leak occurs in the pleural space, and when the patient coughs or exhales. If you spot unexpected bubbling in the water seal chamber, notify the physician and assess the patient for signs of respiratory distress. Suspect a new air leak, which can occur when air enters the drainage system or the pleural space. To locate an air leak, place a padded clamp on the tubing closest to the insertion site. To avoid raising the pressure in the pleural space, don't clamp the tubing for more than 10 seconds at a time. With the clamp in place, check the water seal chamber for continued bubbling. If the bubbling stops when the clamp is placed near the chest wall, suspect an air leak in the pleural space or the lung. If the bubbling persists, apply the clamp at close intervals, moving along the tubing toward the drainage system. When the bubbling stops, suspect an air leak proximal to the clamp. That's because placing a clamp between the water seal chamber and the air leak blocks the air that causes the bubbling. Depending on the air leak's location and cause, remedy the problem by tightening loose connections or replacing the drainage system. Next, check the suction control chamber. For a patient receiving wet suction, assess the chamber's water level by briefly stopping the suction to halt the bubbling. Then inspect the water level, which should be at the prescribed amount, such as -20 centimeters. If the water has evaporated and its level is low, add enough water to reach the amount ordered. For a patient receiving dry suction, make sure the suction control regulator is set at the prescribed amount. To help determine the effectiveness of the chest tube and drainage system, thoroughly document your assessment findings. For a patient whose pneumothorax is resolving, expect to record normal, easy respirations without dyspnea, symmetrical breath sounds that reach the periphery of the lungs, including both apices and bases, reduced drainage in the collection chamber, little or no tidling in the water seal chamber as a sign of lung reinflation, and a chest X-ray that shows resolution of the pneumothorax.
Excuse me, doctor. Mr. Smith is doing pretty well. His respirations have been good. His oxygen saturation has been greater than 95%. Also, he's had no shortness of breath.
When the pneumothorax has resolved, prepare to help the physician remove the chest tube and discontinue the drainage system. To confirm that the patient's ready for chest tube removal, assess for symptoms such as dyspnea and chest pain after the tube has been clamped. Within 2 hours, send the patient for a chest X-ray to verify continued lung reinflation. Then prepare the equipment for chest tube removal. Be sure to include a suture removal kit, 4x4 gauze pads, sterile gloves, petrolatum gauze, surgical tape, and clamps. After providing analgesia or sedation, begin the procedure by clamping the chest tube if this wasn't done earlier. Then remove the dressings from the chest tube insertion site. When the physician is ready to remove the tube, expect her to have the patient perform the Valsalva maneuver and bear down.
1, 2, 3.
This maneuver helps prevent air from rushing into the pleural space when the chest tube is removed. As soon as the physician withdraws the chest tube, cover the insertion site with petrolatum gauze and 4x4 gauze dressings. Secure the dressings with surgical tape and provide other follow-up care. For example, send the patient for a chest X-ray to confirm that the pneumothorax hasn't recurred. Continue to monitor the patient for signs of recurrence of the pneumothorax and evaluate and document his condition. Be sure to ask about chest pain and shortness of breath. Auscultate his breath sounds at least every 4 hours to check for diminished sounds. Monitor his oxygen saturation level to detect hypoxemia. Assess the chest tube site for signs of infection. And monitor chest X-rays for recurrent pneumothorax. As you've just seen, your role in caring for patients with chest tubes is a challenging one that requires expert clinical skills. But you can rise to that challenge every time when you know what to do before, during, and after chest tube insertion.
Okay, let's go back to where we were. So the physician decides to put in a chest tube. What do you need to do? Get the equipment. What kind of equipment do you need? Chest tube insertion, suction, gown and glove for the physician, mask, headgear. What probably do you want to do for the patient? Give him something, some analgesia prior to doing it. Get the tray. What size are chest tubes?
14 unless they're big drinks.
They come in big sizes too, like 28. So it's like the size of your index finger, and they're inserted with what is called a trocar, which is a pointy stick. Looks like a big giant knitting needle inside there, and they just jam that in between the ribs in a stabbing motion. That's why it's called a stab wound. Chest tubes going in and coming out hurt. So make sure that you give your patient something, if possible. I mean, if you're in a tension pneumothorax, you got to release that pressure right away. But hopefully somebody's pushing something. So you set up the system. If it's a dry or wet, if it's wet, you need to fill it. Check your pressure. Make sure sterile technique is maintained. Now, how do you make sure sterile technique is maintained? Right. Now, if you see the physician turns and like hits his hand on something, what do you do? So tell me how you do that. Your gloves are contaminated? Or I usually just say, here's some new gloves for you. I don't have to say you contaminated yourself. I just, depends on the doctor, but usually if you call them on it, they're pretty good about it. And then the petroleum gauze, and position the drainage below the chest. So often you'll see chest tube or collection units taped to an IV pole down low. If you're sending a patient off to get a chest X-ray, stop the courier from picking it up and hanging it from the back of the wheelchair, because what happens then? Just slops back into the patient, right? Whatever drainage there is. And careful of these when you are lowering the bed, because they like to, scoot under the bed and then you crack them in half. I've done that. It's a big mess. Not much fun either. So we are going to, and then patient position. If you do this at the bedside, what position will you put the patient in? Over the overbed table. Yeah. They're sitting up, or to the side, but over the overbed table. So they're tripoding, right? We're going to do another group quiz. So get in your groups, and you're going to do quick true false quiz. Oh, you're just so sick of it. Just think of how these are just going to increase your, I don't know, I'll have to look. I just decided this during the movie. There are 10 questions. There they are. True or false? We'll go over them afterwards. So read them, go true or false, and then you can exchange it and everybody can correct it in other groups when we're done. So we have 5 minutes. Ready, set, go.
Yeah, it's just such a, yeah,
I only see one group using the resources they were given.
Alright, so next time, the other quiz.
Okay, 3 more minutes.
You guys say true? True.
Everybody ready? Ready? Swap with another team to correct your answers. You have to do a three-way swap over here. Well, somebody's going to have to take theirs. No, you're going to have to give them theirs. Has anybody taken theirs?
Nobody has their own, right?
Does anybody have their own paper? Everybody switched? Not that you'd cheat. I know you wouldn't do that. Okay. Oops. True. Number 1 is true. Number 2 is Number 2 is false. Negative 20, not positive 20. Negative 20 centimeters of water. It's a difference. A huge difference. Number 3. True. Number 4. True. Number 5. False. Chest drainage system is not a closed changer. That water evaporates over time. That's why you have to keep an eye on it so that you top it up. That's 5. 5 is false. Number 6. False. You never strip the drainage tubing. A long time ago when this young nurse was first doing post-open hearts, we routinely stripped chest tubes because the clots are coming down. So stripping a chest tube takes lotion. You put lotion on your hands and then you take it and you collapse it upon itself, pull it down here, release here, so it goes, right? It suctions out it. We used to do that. That was standard practice. But think of the amount of pressure that you're putting on. You can have 400 centimeters of water pressure when you do that. That easily rips off a coronary artery graft that was just sewn on a heart. So don't ever do that. But we used to routinely do it. There was even a little mechanism, a stripper. We would order it up. It was a roller thing. We would strip along. Surgeons may still do this. You may still see one come in if they've got a clotted up tube. They may, but let them do it. Don't strip tubes. But we used to have a great time stripping tubes. It was routine. Don't strip tubes. 7 is false as well. Clamping the chest tube in the presence of an air leak can result in a tension pneumothorax. If you disconnect the tubing without clamping, the tubing, the lungs can fill with air and suck the air in. So you need to clamp briefly to exchange. So it's true. You lower, because you know an air leak, you may clamp the tube for a short time it takes to reestablish the drainage system. Well, if you clamp it in the presence of an air leak, what you want to do actually is, how can you maintain a sealed, if you clamp it, they can't breathe in or out, correct? So really what you want, every time they exhale, you want air out of that potential space to go out the tube, right? If you don't, Every time they breathe in, they'll fill it more and fill it more and fill it more, and they'll get a tension pneumothorax. So what do you do if you have to run and get a new tubing in this? Yes, you put it underwater because you want a water seal. Where are you going to grab? What are you going to do if you're in the room and this all happened? How are you going to put it underwater? Their water jug off their bedside table and just jam it in there, yes. Because then you create a seal. Think about it. When they exhale, does anybody confused by that whole process? Okay, so they have a tube hanging out of their chest that is in the pleural space, which does not normally have air in it, correct? But now it has air in it, and if there is every time they inhale themselves, they can be pulling air from their lung into that potential space. If you clamp it and that air can't come out of that space, that pleural space, every time they breathe in, there's more air in that space, more air in that space. And as that air fills up, we have a tension pneumothorax where it's pushing on the lung and then pushing over onto the heart and creating a tension where they'll arrest. So that's why you want to put it in a water seal. Does that make sense?
I'm confused on 7 though, because what's the difference between short time and briefly to reestablish a drainage system?
Well, okay, think about how long would it take you to run out of the room, go get all this stuff to recreate it, because it just broke in front of you. It's not like you have it sitting there. You would be gone for longer than 10 seconds, because it says you can clamp for 10 seconds. Because you can clamp, switch it. That's 10 seconds, but you can't clamp, run around, and get everything. Okay? Does that make sense?
Because the other way, you would have it set up ready for you to... Well, I
Right.
understand that, but if you look at the rationale, it says therefore you need to plan briefly to exchange the broken channel for a new one.
Yeah, briefly versus a short time.
Briefly versus a short time. Per the wording is poor Ray.
My concern is that the outside of the tubing isn't sterile, so that when you put it in, the water, it could potentially get germs in the sterile solution and pull it into the pleural space. But I guess if it's an emergency, it doesn't care.
Death or a little bit of dirty tubing.
But you just clamp it while you're establishing the system. So you have it in the water,
Right.
and then you clamp it, take it out of the water, and put it into the
Right.
So that's how I read number 7. You have the equipment. It doesn't say you may clamp the chest tube while you go get the equipment. It says while you reestablish.
Well, look at. You lower the bed on the drainage system and break it. What do you have a backpack on with all the equipment in there already?
I think that's a poor question.
Okay, it might be a poor question. Yes. No, you broke it. So now you broke it. Yeah, I don't think they're not walking around with them in backpacks either. Okay, number 9 is true, 8 is true, 10 is true. 10 is true. Yes.
So it says that it's called, it's not a closed system, but in the handout you gave us, it says a monitoring medical surgical nursing procedures chest tube to closed chest drainage system.
It's a closed dress drainage system, but it's not, there will still be evaporation from it. Just give it all back to me, and these were intended to be bonus points, so whatever points, they're going to be bonus, okay?
Bonus goes towards those quiz grades.
Yeah, they go towards the quiz grades as bonus.
Do we
So-
put names on it, or just the water version?
I know who the people are now. Or whatever you earned. All right. Take 5 minutes, and then we're going to go back and see what we did to this horrible guy, the poor old man. I didn't. Okay. So now we have, what's his name again? Sam? Sam I am. Oh, what are we doing here? chest tubes removed. He's discharged on day number 3, and he's since being diagnosed with obstructive sleep apnea. He's lost 10 pounds. There's been little improvement with his symptoms, and he realized the car accident was because of his sleep apnea, and he wants to talk about other treatments. So what's out there? There's a dental appliance. You can go to your dentist and get this thing that will make your turtle chin go forward. CPAP, BiPAP, this is pretty much the gold standard right now. Or uvulopalato-pharyngoplasty. A uvulopalato-pharyngoplasty. So they go in and they pretty much saw out your uvula, all the soft tissue. They're making a bigger chamber. And it only has a 50% success rate, yet they continue to do this surgery. Tracheostomy is another option. So a trach that you're connected to your CPAP or BiPAP at night through your trach. So Sam decides least invasive treatment. I'm going to go with the CPAP, and he gets a prescription for it. The Durable Medical Equipment Company brings it out there to him. Yeah, he's changed ethnicities again. He has no hair, and he is Caucasian now. And so 2 weeks later, he calls and he goes, I hate this thing. My nose just bleeds all the time. I'm all dry. My ears are sore. What do you tell him? If he's all dry, we're going to do what? Humidify. Make sure that the mask fits. And nasal spray. And whose patient was that? That poor guy. That was your guy. You got your mouth full, sorry. Some patients have a really hard time sleeping with that CPAP on or BiPAP. And these machines actually measure the pressure, and they self-adjust. So when the patient starts to become apneic, it bumps up the pressure. So for some, it has to be a lot of pressure. The other thing is the claustrophobia. Like this guy's, can you imagine how you sleep with that thing on your head? You're really attractive. So there's newer models of masks they have now that are just sort of like nasal cannula looking, that just sit in the nose. They don't have to have the whole headgear on. So there are other options, yes.
I've seen one, my patient had one that was just around the nose.
Right, they have just around the nose. And they have ones that just sit in the nares. And then they have this big headgear one. So 6 weeks later, Sam returns for a follow-up appointment, and the CPAP hasn't worked. So, well, we're just going to trach you then. We'll put a number 8 Shiley in with a disposable inner cannula, and he's becoming increasingly anxious after receiving this news. How are you going to prepare Sam and his wife about this? What would you tell them? Oh, it's just a hole in your neck. No answers? Well, so we're going to teach them. You're going to show them what it looks like. You're going to give them visual aids. I put this up here because this happens to be a blog that this man over here on the left talks about his trach. And it's kind of interesting if you take time to listen to him and read through his stuff, how he's adjusted to his trach. So when someone has a trach, when our upper airway has a function, what do? You humidify. We have all nose hairs for a reason, to catch all microbes and little dust particles and bugs. You know, and we humidify. If your trachea comes straight out of your throat and a bug flies, right away, you could get into it, right? We've lost the filter. So there is such a thing as little special dickies and cravats. Did I say that right? A little tie, but they have a special microfiber that sits over top of the trach. Because these people, remember, they don't need someone to breathe for them when they're awake. They need help when they're sleeping because they're apneic at sleep when they're sleeping. So they're up moving around. They could have a button on it, like this guy has his trach buttoned when he's up during the day. But if he has his trach open, he could have one of these little filters. If it's a woman, she could have like a fancy scarf, right? So there's that whole body image issue. Think about it. Last week we talked about not having any hair. This week we have like a hole hanging out. Do you guys remember that television commercial, the woman smoking with her trach? And that comes out of there? It's one of my favorite commercials ever. Every time it's on, I show my husband, look it. Could be you. Doesn't work. Doesn't work. Doesn't that seem crazy? But if it's not working for you, a trach or a stroke.
I have a good question. So if he ended up losing weight and somehow
He might not need it any longer. Yes, most definitely. I tell myself that all the time. You know what, you take 50 pounds off, you probably wouldn't eat that thing up your nose. Anyway. But we don't always listen to ourselves. Body image, stoma protection, so no bugs fly into it. Communication. Is he going to have trouble talking? Not if it's buttoned. But if it's open, yes, he will have trouble talking. And educate others. Because he has trouble talking, is he deaf? No, people don't need to yell at him. That's a common thing that we see happening. As we're moving into a week of simulation lab, we are moving into a week of learning all about chest tubes hands-on, trachs hands-on, trach suctioning hands-on, and central line dressing hands-on. That's going to happen next week for all of us. So we're going to be able to practice these things and manipulate them. Just having a little intro into class right now. There's some great videos out there that now work. Please keep sending me messages if something doesn't work on Blackboard, because remember my big cry at the beginning of this semester where it didn't transfer nicely. So he goes under the tracheostomy procedure without complications, and when we return, you know that the trach tape, this is trach tape here, it's twill tape. It also works really well for removing rings. I can show you that trick sometime. And you know the tape looks tight and you're unable to insert one finger between his neck and the trach tape. Is that a problem? Yes, it is a problem, because if that flange pushes down on there and he's swelling, you're going to end up compressing the stoma itself, infection, leakage. If the trach, the back of the trach is on the back of the trachea, what runs up the back of the trachea? What else runs up there? The innominate artery. So if you keep grinding, if you see your trach and it's pulsing like this, the same as the patient's pulse, what's it sitting against? An artery. What could happen? A fistula could occur. Then what happens? It's a bloody mess. They bleed. Aspirate, not good. So, red flags, a pulsing trach. Dislodgement less than 72 hours, what are we going to do? Bag them. We're not going to pick it up and then put it back in, right? 72-hour rule, right. If it's greater than 72 hours, that stoma has probably established itself, and we're going to have a trach at the bedside, which is the same size as the one that went in. So when you're getting a report of somebody coming back from the operating room and they have a trach in place, you're going to say, what size is it? This was an 8, right? Pick up materials. I need a size 8 shyly. And you have it we just tape it on the wall behind the patient's bed. Then we know where it is. Putting it nicely neat. You know, anything that you put in the room is not where you put it, right? If you tape something on the wall, it pretty much stays on the wall. If you come in and a trach is doing this, hanging out there like this, what do? Well, if it's greater than 72 hours, I go like this, push it back in. If it's under 72 hours, I'm going to try and stabilize it and get somebody to come in and help me. Whenever you're changing a trach tie, two people need to be there. 2 hands are not enough, ever. Don't think you can do this by yourself, because guess what happens? There's a big cough, and this big rope of sputum flies out and hits the wall, and the trach is stuck to the side of the wall with it. This big old rope goop hanging there. Housekeeping? I don't think so. That's nurse. So what are your actions going to be? You see this stuff? This happens? What are you worried about? What are you going to do? Before you do the incident report, you're going to call the doctor. If the doctor isn't at hand and able to come in, you're going to take care and retie it, because you need to get a finger in underneath there. You don't want it so tight that and document it and say that there's an incident report, because you want to document. Incident reports aren't blaming anybody for anything. They're documenting that something has occurred. So you want to document that you found this trach tied too tightly. So you know the tissue around the incision is edematous, and as you look at him now, poor Sam. It's edematous. As you palpate the area, your fingers sink into the skin, and you auscultate a popping sound through your stethoscope. Is that expected? No, that's called subcutaneous emphysema. This is what this guy has. He has sub-Q emphysema, which has, what does air do? Rise. So it has risen through all his subcutaneous tissue in his head. You see these patients, they can't open their eyes. It's not funny, but it's kind of, you walk in there and they go, yeah? Because they can't open the lids of their eyes. They have all this air that is in their subcutaneous tissue. What? So we had a patient like that just last year. Poor guy. What do we do about this? We wait for it to resolve. We wait for it to resolve. If it's bad, really bad, they can just like needle in and release the air with the needle, but you rarely see that. It just sort of takes time and it is absorbed. This is what it looks like on X-ray. All this kind of air stuff, this white fluff, is not really expected to see above the clavicle. That's more like you'd see that inside a lung, right? So that's what it looks like on X-ray. So it's not expected. Notify the doctor, explain what's going on to the patient, elevate the head of the bed, and explain what's going on, then it's not harmful. When you feel it, it feels like real small bubble wrap. You know, when you run your hand over bubble wrap and there's that crackling sensation, that's what it feels like. It sounds like when you pour water over or milk over Rice Krispies. You know that snap, crackle, pop, they call it, but you know that sound? That's what it kind of sound feels like. So that's something that you can look for. Yeah, maybe. Bubble wrap. Crepe paper. I haven't seen crepe paper in years. You're old. Streamers are made out of crepe paper. You know the streamers? That's crepe paper. Okay. I'm not going to move into Brian because it's already... Well, maybe I'll start Brian. Brian is 22 years old. He lives in a small mountain town in Colorado, and he's allergic to dust, pollen. Anxiety appears to be a role in exacerbating his asthma attacks. His wife drove him to the clinic because he's unresponsive to his fluticasone and his ipratropium bromide, which is Flovent and Atrovent inhalers. He's unable to lie down. He began using his accessory muscles to breathe. And these are his vital signs. You put him on 4 liters nasal cannula. You put an IV of D5 in him for KVO, and these are his blood gases. Let's talk about blood gases for a little bit. So, pH, what is it? To what? So, okay. And CO2? 35 to 45. So that leaves 22 to 26. Okay. Yes. Jeff. Joan is what?
21 and 28.
Okay. This is probably what you're going to see in the hospital the most, but 21 to 28, 22 to 26. Bicarb. It's metabolic, right? Okay, so if the CO2 is affected, it's rest. If these two are out of range, it's respiratory, right? If these two are out, it's metabolic happens. Well, yeah, but metabolic takes time to occur. Respiratory changes happen quickly. Okay, we can become alkalotic or acidotic respiratory-wise fairly easily. We could do it right here. If we started to hyperventilate, we could do it, right? Okay, so knowing these, you can figure out if it's respiratory or metabolic acidosis or alkalosis based on your arrows going up or down or what's going on, correct? How do you know if it's compensated or uncompensated? Compensated is that you're just looking at the pH. If it has come back to normal, it has had to change and come back to normal to be compensated. So if it's compensated, there's no change, there's no up or down happening, right? If it's uncompensated, see, this is, yeah, these are outside of their parameters. So if these are outside, then it's uncompensated. It has not come back. It hasn't had time to equalize or return to baseline or homeostasis or however we want to say it. So these are the gases according to Sue, the way they make sense in my head. Now, gases are something that you have to interpret all the time, or you forget what you're doing, right? So this guy he's acidotic, he has respiratory acidosis, his bicarb is normal. So why does he have respiratory acidosis? He's wheezing. Okay. He's retaining his CO2. In asthma, what happens? It's complex. It's a chronic inflammatory disorder. So what we are seeing is inflammation of the bronchioles. So we see all that. We go into a spasm. We have narrow bronchioles. The cilia becomes plugged up with mucus. There's not that normal cilia motion moving things around. And it is because it is what? What causes all this? Constriction, but what happens? It's a what? It's an inflammatory response. Is it an appropriate inflammatory response usually? So it's an inappropriate. Is it an autoimmune response? Yeah. Some people classify it as an autoimmune disease. It kind of hovers in between a chronic respiratory disease and an autoimmune disease, but regardless, it's a chronic disease. Asthma is a chronic disease, but it is reversible. It is activated by that immunologic immune response where we see that IgG is released and it goes racing to this, what it perceives to be an intruder, whatever the inflammation might be. And we have decreased lung compliance, impaired mucociliary function, and altered gas exchange. So we have this autoimmune response that usually reacts to an allergen. So if the individual knows what their allergens are, what's the best thing for them to do? Avoid them. So now I'll tell you a story about a ICU nurse who was away with her colleagues in Atlanta, Georgia at the National Teaching Institute for American Association of Critical Care Nurses. This ICU nurse is a lifelong asthmatic and is known anaphylaxis to fish and seafood. You may know her. So one night with her colleagues, she decides to go to Benihana's because it's a cool place to go. So sitting there with her friends at Benihana's in front of the chef who's cooking shrimp in front of her, the aroma of shrimp in front of her, and she's breathing in and out this known allergen. And all of a sudden realizes she can't breathe. So fortunately has her inhaler in her purse, right? Pulls out her rescue inhaler, which is a albuterol, so it's a short-acting beta-2 agonist, right? Not doing nothing. Not working. So she gets up and goes outside the restaurant with the waiter behind her going, "You need to pay! You need to pay!" and leans over top of a newspaper machine to do this. Why? All right, trying to take pressure off, trying to get full lung expansion, right? So finally one of her colleagues realizes that maybe, I think she's allergic to something here. Maybe I'll go check on her. So she's leaning over, not moving air, right? Oh, well, maybe we should deal with this. Yeah, let's go deal with this. Call a cab. Get in the cab. She still remembers that there was this saxophone in the middle of the cab. Sitting in the front seat doing this now. What is she doing now? Posturing, right? Trying to expand lungs, trying to get air in, doing this, not moving much air. Wheezing is not happening any longer. What are we going to do? There's a sign to the emergency department. The colleague says, "You want to go there?" No, let's just go to the drugstore. So we go to the drugstore. The colleague runs in to the drugstore. What does he grab off the shelf? No. Benadryl would help. That's an antihistamine, right? That would help with part of this process. What else do we need? Can you just grab that off the shelf? Huh?
You can, but it's a little more illegal than someone can't get to it.
Can't get to it unless you had a gun. They won't just give it to you. But we have to remember this is like 15 years ago, and it was just within the last 5 years. You can't get this on the shelf any longer. What is it? No. But that's a good drug, too. No. Primatene mist. Does anybody remember what primatene mist? Bronchodilator. What's the active ingredient in primatene mist? Those of you on your computers could pull it up right now. What is it? I just heard someone say it. It's epinephrine. So he runs up, throws the 10 at the cashier, runs out with the epinephrine. Half an hour later, drinking a beer. Not at Benihana's. Okay, so does she have an EpiPen now? Yes, it's outdated, but I do have one. This lifelong asthmatic did everything wrong. An educated lifelong asthmatic. At that time, probably, no, I guess I didn't have a bachelor's by then, but I was a nurse, as an ICU nurse, for God's sake. Which is why I didn't want to go to the emergency department, right? I just wanted to self-treat myself with some epinephrine. What did I want? I wanted epinephrine and Benadryl. I think I might have got some Benadryl, too. Beer.
To go with the Benadryl.
In an emergency, what would I take? Pills or liquid? Liquid. And then I would sleep. I don't think I took it because I had to go to the bar. Oh, I'm taping this. So we will pick up later, but what we learned from this story is no. Asthmatics need to have a plan. And if you don't have a plan, you can be dead. I was really lucky. That was really wrong. Do I have a plan now? I have a sort of a plan. With an expired EpiPen.
My daughter is asthmatic, and I always carry Benadryl and EpiPen in my bag.
Yeah.
She has all kind of allergies.
You know, if it was